Hyperglycemia is common in patients with the coronary artery disease. Why there is a lack of diagnosis?
Some 70% of all patients with established coronary artery disease, but almost very likely also in heart failure patients, do have diabetes, either diagnosed around 25 to 30%, undiagnosed some 20% on top of that, and also 1/4 with what has been called prediabetes, impaired glucose tolerance. And the reasons for that, of course, are multifactorial, but one is that clearly there is also insulin resistance involved with that, and this is together with obesity, one of the driving factors for hyperglycemia and diabetes in those patients. Now, it has clearly a tremendous impact on the further prognosis of those patients. In fact, even for some therapy, as we discussed for bypass surgery and so on, it is important to know whether or not the particular individual patient does also have diabetes or at least prediabetes.
How much is useful to detect diabetes and prediabetes to predict cardiovascular diseases?
In naive patients who don't have cardiovascular disease, there's also a prospective high increase of developing cardiovascular complication. Again, at the end, if you pursue patients over 30 years or even 40 years, some 70% finally will die from cardiovascular complications. So this is still by far the most significant risk in people with diabetes, that they develop atherosclerosis and the whole cardiometabolic risk spectrum, including heart failure, and this all contributing to premature death in patients with diabetes.
And what kind of tests to screening disorders of glucose metabolism?
Well, the European guidelines, joint guidelines between the European Association for the Study of Diabetes and European Society of Cardiology, recommend a two-step approach. Since it is so common, it's not really recommended to use risk scores or like the find risk to enrich the population, because if 70% have abnormalities, you start with the measurement first. Now, what is suggested to do as the first step is a combination of hemoglobin A1C measurement and fasting plasma glucose. So this is fairly simple. And if you make the diagnosis of full diabetes, then this is the end of the diagnostic paradigm. However, if those values are below the threshold of overt type 2 diabetes, you have to do the second step, and that means in patients with a fasting below 7.0 millimole or 126 milligrams per deciliter, or an A1C below 6.5, which is the diagnostic threshold for diabetes. In all those cases, go to the oral glucose tolerance test, and you will find an enormous amount of undiagnosed diabetes, which is largely defined by the postprandial increase or IGT. As mentioned earlier, some 25% of all people with coronary artery disease, heart failure, do have this type of prediabetes. And also this impacts on the prognosis of those patients.
What are the indications of EuroAspire in the screening of dyslipidemia in coronary artery disease?
Well, in EuroAspire 4, this was the first population where this diagnostic paradigm I just described has been evaluated. And they had some 23%, I think, of known diabetes. And so there was a large group, I think, out of close to 9,000 patients without knowing whether or not there is diabetes or prediabetes. And those were subjected, some 4,000 patients, to the triad of measuring A1C, measuring fasting glucose, and doing an oral glucose tolerance test. Now, what was found there? By far, the most cases were undiagnosed cases were picked up by fasting plasma glucose, 75%. More than 40% were picked up by postprandial glucose, and only 17% were picked up by measuring A1C. So clearly, this is why if the A1C is below the diagnostic threshold, there still is a very high likelihood or possibility that there is still undiagnosed diabetes. And this is really the benefit coming out of this EuroSpire 4 investigation.